So, good afternoon and welcome to this symposium on highly effective modulator therapy effects on hallmarks of CF airways disease. My name is Markus Mahl from the Charité Medical Center in Berlin, Germany, and I'm co-chairing this session together with Deepika Polanini from University of Washington in St. Louis, and also together with Trey De La Rose, our community speaker. And I think it's really great that you could come here and join us and also provided the patient perspective to this symposium. So from a medical perspective, highly effective CFTR modulators have really transformed or provided unprecedented improvement in clinical outcomes and transformed the life of our patients. However, many of the hallmarks, the key features of CF lung disease that we've known for a long time, i.e. impaired CFTR chloride channel function, but also impaired mucociliary clearance, infection and inflammation, have not really been addressed in clinical trials. So the aim of this symposium is now really to review the emerging data from observational studies on these key features. And the idea really is to get a deeper understanding of where we stand in terms of tackling the pathophysiology of CF lung disease, but also get a feeling for the unmet needs, both for our patients and also in terms of future therapies. And with this, I would like to hand over to Trey to give us his introductory words.
Thank you, Marcus. Hey, everybody, I'm Trey La Rosa. I'm an adult with cystic fibrosis. And I really want to just kind of ground us before this talk to really highlight the importance of understanding really what modulators are doing at the biological level. For me personally, I've benefited profoundly from Trikafta. My lung function has gone up about 15%. I'm hanging out at 100% lung function, FEV1. My CFTR function has also dramatically improved, probably unsurprisingly to most of you. Prior to Trikafta, my sweat chloride was about 110, and it's since dropped to 45, which is pretty unbelievable. But for me, I think that one of the most important things is really understanding what's happening so that we can hopefully inform future drug development and improve drug design to ensure that these modulators and other highly effective therapies become available to the broader population across the world with CF. And as you all know, there's a lot of people who are still in dire need of really this amazing change in life. For me, I don't do treatments anymore. I don't do BEST. I don't have to do any inhaled therapies, and it's been pretty amazing. But I think that there's still a lot to be understood, and I believe strongly that understanding the basic science of what's happening is fundamentally important for the future of drug development. And this is just, I'm really looking forward to these talks today, and it's an honor to be here. So thank you all.
Thank you so much, Trey, for your opening remarks. And we'll start with our first speaker, Dr. Simon Graber from Charité Medical Center in Berlin with restoration of epithelial CFTR function.
Yeah, thank you very much for that kind introduction, and thank you very much for the invitation to speak at that great conference. So I will tell you a little bit about the restoration of the epithelial CFTR function. Here are my potential conflict of interests. So we all know that we now have CFTR modulators available to restore CFTR function in patients with CF. And we have a combination of correctors and potentiators that are now available for about 90% of genetically eligible patients. And we still have about 10% of the patients that are currently cannot be treated with modulators. And the goal, of course, is a full restoration of CFTR function. But what we need to know is what is the extent of CFTR correction by the currently available CFTR modulators, and to know if there is a way to improve them, and also if we can transfer that knowledge to patients that are not currently eligible for highly effective modulator therapies. So how do we measure CFTR function? And there are measurements of in vitro CFTR function, and mostly cell lines, Fisher red thyroid cells are used by Vertex and the FDA. I will come later to that. And then there are primary epithelial cells derived from the patient with CF from the airway epithelium, like primary nasal epithelial cells or bronchial epithelial cells, and intestinal organoids derived from the intestinal tissue that has the advantage that there are very high amounts of CFTR in the intestine. And then we have measurements of in vivo CFTR function, where with nasal potential difference measurements, we can measure live the CFTR function in the patient at this moment. Then we all know about sweat chloride concentration, which is an indirect measure of CFTR function in the sweat gland. And we have the intestinal current measurement, where we can measure CFTR function in the rectal epithelium derived from rectal biopsies from the patient. So when we look back at the beginning, for ivacaftor, it was shown that ivacaftor improves CFTR function in Fisher red thyroid or FRT cells. And it was clearly shown that FRT cells transfected with G551D show a great response compared to delta F508 FRT cells. And that was confirmed in human bronchial epithelial cells, where there was a great improvement in a patient with delta F508 and G551D. And on the right side, you can see that this response is a lot bigger in the G551D patient than in the delta F homozygous patient. When we looked at the in vivo CFTR function improvement by ivacaftor, we did a study in patients with the G551D mutation and saw that in the intestinal epithelium, the CFTR function was rescued to about 50% of normal CFTR activity. Looking at lumacaftor, ivacaftor, which we all know that its clinical benefits were a little bit lower with improvement in lung function of about 2 to 3%. In the in vivo CFTR biomarkers, we observed an improvement to about 10% in the respiratory epithelium measured by nasal PD and to about 18% of CFTR function in the intestinal epithelium measured by ICM. Now looking at elexacaftor, tezacaftor, ivacaftor, those are data from the human bronchial epithelial cells from patients with delta F508 and a minimal function mutation, as well as delta F508 homozygous patients. And here you can see the Western blot to show the C band of the functional CFTR protein. And you can see that the triple combination in the minimal function patients and the homozygous patients shows a high degree of band C. And when you look at the chloride transport, you can really appreciate that the triple combination of all three drugs has the highest increase in CFTR function in both the heterozygous patients with delta F and the homozygous patients. We then wanted to know how that translates to the in vivo CFTR function, and we have a current study running in Germany. It's a multi-center observational trial on the real-world effects of ETI called Modulate CF, and it has different sub-studies with biomarkers of CFTR function, clinical endpoints like LCI and MRI, sputum properties, and patient-reported outcomes. I will focus on the biomarkers of CFTR function, but if you're interested in sputum properties, you can also go and have a look at the posters. So as I said, this study was performed in the German Center for Lung Research at 4 centers. We included 107 patients. About half of them had delta F508 and a minimal function mutation, and the other half were delta F508 homozygous patients. We had a baseline measurement with sweat chloride, nasal potential difference measurement, and intestinal current measurement. And after 3 months of therapy, so short-term repetition with all the 3 biomarkers. And in the homozygous patient group, we had a step in between with tezacaftor, ivacaftor for patients who were treated with tes-iva before. In sweat chloride, we basically confirmed the phase 3 clinical results that in patients with delta F and a minimal function mutation, sweat chloride was reduced by about 50 millimole per liter. Looking at the respiratory epithelium, we saw an improvement to about 45% of normal CFTR activity in the nasal PD. And in the rectal epithelium, we saw an improvement to about 40% of normal CFTR activity by ICM. In patients homozygous for delta F, we observed an improvement of about 10 millimole per liter by tes-iva and 60 millimole per liter by ETI. In the nasal PD, ETI improved CFTR function to about 50% of normal CFTR activity, and in the intestinal current measurement, again, about 45% of normal CFTR activity. We then looked at the biomarkers in different tissues and compared them, and we observed that there's overall, across all measurements, a very good correlation between sweat chloride and the airway epithelium CFTR function, the intestinal function, and between NPD and ICM. But you can also appreciate that there's a substantial number of patients where measuring different biomarkers really gives you additional information. Looking at the correlations between improvement in lung function and basic restoration of CFTR function, you can here see a correlation between the change in FEV1 and the change in the CFTR function after starting ETI. And you see that there's a slight correlation between sweat chloride and FEV1, no correlation between FEV1 and nasal PD, and again a slight correlation between FEV1 and ICM. And I think this really translates or is explained by that we have chronic lung disease that is probably not reversible, like bronchiectasis, which does not directly correlate with improvement in epithelial CFTR function restoration. Interestingly, when looking at the total data observed after ETI therapy, like in the clinical trials, we saw a gene dosage effect for sweat chloride. So patients delta F508 homozygous had a median sweat chloride of 35 millimole per liters, whereas patients with a minimal function mutation dropped to 50 millimole per liter. But we did not see that difference in the respiratory or in the intestinal epithelium, suggesting a potentially tissue-specific gene dosage effect of ETI. So to summarize, I think the current highly effective modulators show a partial improvement of CFTR function to about 50% of CFTR, normal CFTR activity. So I think there is still room for improvement for full correction, or at least correction in the range of heterozygous carriers. And then coming to the 10% of the patients who are currently not eligible for CFTR modulator therapy, when we look at modulators, I think we have to look at the 5% that have rare mutations that at least make protein. And we do have very good model systems we can use, like nasal epithelial cells, bronchial epithelial cells, or intestinal organoids to look at if these patients might respond. And when we go back to the FRT cell model used by Vertex that already worked for ivacaftor, where they showed that more than G551D really respond to ivacaftor, which led to a label extension. And then for ETI, we all know that the FDA approved 177 additional mutations based on the FRT cell model, and there they use a threshold of at least 10% of normal CFTR activity to predict clinical response in these patients. When we now look at rectal organoids, also of patients that are not FDA approved, like the S1159F mutation or the R334W mutation, you see that they have a organoid swelling in the range of ETI in minimal function mutations. And you have some other mutations that show swelling of organoids in the range of lumacaftor ivacaftor. In the therapytyping in the French compassionate program, they use primary nasal epithelial cells, and you can see here FDA-approved mutations in dark blue, and in light blue non-FDA-approved mutations. And you see that some patients with those mutations have an improvement of about 10% of wild-type CFTR function in these in this model system, although they are not approved for by the FDA. And the interesting part about the French compassionate program, that they were able to treat all these patients with ETI for at least 4 weeks and look at the clinical outcome in these patients. And here they observed in the total cohort that patients that improved in lung function more than 10% had really an increase in CFTR function in the primary nasal epithelial cells. And interestingly, when you look at the non-approved FDA mutations, then you can see that patients that improve lung function of more than 10% of FEV1 show a median increase in CFTR function by about 5% of normal CFTR activity. But interestingly, when you now look at the sweat chloride, it doesn't become that clear when you look at the non-FDA approved mutations. Only 6 patients show a sweat chloride improvement more than 20 millimole, and they only have an improvement, they again have an improvement of 5 millimole. Which led us in those 2 studies and in other studies, N1303K as a special class 2 mutation was also identified as a responder mutation. And here I picked an example of an intestinal organoid of a homozygous patient where there's a clear swelling in intestinal organoids. And it was confirmed by measurement of nasal potential difference, where 2 patients improved to levels that are considered in the healthy range after initiation of therapy. And we measured a homozygous patient with primary nasal epithelial cells and observed that there was an increase in CFTR function in the nasal cells, which was then confirmed here in red by improvement in nasal PD and improvement in intestinal current measurement after initiation of ETI. And across all studies now, it was shown that ETI in patients with N1303K was also associated with substantial clinical benefit. But interestingly, mostly no or only minimal response in sweat chloride concentration was observed in these patients. And I think this brings us to the questions if the threshold of the 10% that is used in the FRT cell model, if this is really correct to predict clinically meaningful response in patients. So to summarize, I wanted to show you that ivacaftor improves CFTR function to about 50% of normal CFTR activity. Lumacaftor, ivacaftor, and Tez-Iva improve CFTR function to about 10 to 20% of normal CFTR activity. ETI in patients with at least 1 delta F508 mutation improves CFTR function to about 40 to 50%. There might be a potential tissue-specific effect of ETI. And I think there's still room for improvement, and potentially more effective CFTR modulator therapies are necessary, obviously for full restoration. And I think we will see in the remainder of the session if it is really necessary to go higher in improvement in CFTR function. And I think we have very good preclinical model systems that can really predict responders to therapy. And we have in vivo biomarkers to confirm these responses in vivo. And I think the example of N1303K shows us that we have to discuss if that 10% threshold is really right to predict clinical response. So with that, I want to thank especially the clinical team of the Charité and also the lab team and you for your attention, and I'm happy to take questions.
And our audience members are welcome to come to the microphones and ask a few questions as well. I see Dr. Solomon.
Hi, great work. Thank you for presenting all that. I wanted to get your thoughts about the concept of residual CFTR dysfunction. I mean, we know that some patients develop pretty significant bronchiectasis, sinus disease, coming into the story with, CFTR dysfunction, even less inactivated than patients have that we're showing, post-modulator. Curious about your thoughts to speculate on that question.
Yeah, so I totally agree, and that's what we have seen for years in the diagnostic field, and I know you perform a lot of nasal PD as well. Yep. So that's why I think we still need more improvement of CFTR function. I don't think 50% is enough. We don't know if we really start early in life what that means on the long term, but I agree that from the diagnostic experience we have, that 50% is not enough to completely prevent progression of lung disease.
Great, thanks.
Thank you, Simon. That was great. I have a specific question for the N103K mutation, because you were so kind to show the data of the French compassionate use. And indeed, those who did not correlate for the sweat test and the in vitro correlation were the N103K patients, because they indeed don't really decrease their sweat tests. So there is a tissue-dependent restoration. Probably. So do you have any, because you find exactly the same in your
Yeah. So I unfortunately don't have an explanation why that is, but I think it really highlights that we don't only should rely on the sweat chloride result, and especially in this mutation, but we don't know about other mutations, and the tissue-specific effect we saw in the homozygous or heterozygous patients is also, I mean, what does it help if the sweat chloride doesn't improve? I think the patient can live with that if the function in the respiratory epithelium improves. So that's why I think it's really important to use different biomarkers of relevant tissue, and that's why I think the nasal cells are perfect. If we see a response in nasal epithelium in the primary cells of a patient, then I would be pretty confident there's also improvement in the lung of the patient.
But I must say we do need to learn much from this mutation, because there is also a variable response for these patients, even among the homozygous. And also this tissue-dependent response and variability of the CFTR biomarker is really very intriguing.
Yeah, totally agree. Thank you.
Following up with her questions and comments, I would like to emphasize once more, because I spoke this morning on a workshop, and we actually presented data from this mutation, the N1303K, and to make a long story short, some clinical studies performed by my colleague Charles Esther at UNC Chapel Hill with Duke and UNC clinicians. Make a very long story short, we found out that again, they do respond to ETI perfectly from a lung function point of view, but there was no improvement in chloride secretion, in sweat chloride. And based on all the work that Martina Gensch and I have been doing, that we have been describing the drastic impact of inflammation on enhancing the effect of modulators. So our notion is, and this is about the tissue-specific responses, our notion is that while you do have inflammation in the airways, in the airway epithelial cell, that is helping ETI to really improve the efficacy and the being a beneficial treatment for patients, but in the sweat glands, they are not inflamed. So this could be a very plausible explanation to the discrepant data, and of course, with implications for therapy.
Yeah, thank you very much for that comment. That's, of course, a potential explanation, and I know that's great work you've done. So we don't know yet, but definitely a really good explanation, yes.
Simon, thank you for an excellent presentation. And just one more comment. You've done a really great job of calling into view some of the strengths and weaknesses of these multiple modalities of looking at efficacy, whether in vitro or in vivo. And I guess I would just ask, as we look at the French compassionate paper and see compassionate use paper and see even discrepancies between clinical response versus FRT results, for example, with R334W, or the beautiful graph that you showed with FDA label approvals and that variation that we still see, you've supported that nasal epithelial cells can be a lead contender in terms of looking at correlations of response, but do you have any intention in looking at models of different composites and what maybe can best inform, since each of these has their own limitations and weaknesses?
Yeah, no, I totally agree. I know Isabella has now really nicely shown that primary nasal epithelial cells are a valid model, but we have known for a long time that intestinal organoids are a very good model to predict clinical response. And I think there should be even more models. And I think especially to get out the tissue-specific effect, I don't think we can rely on one model in those specific mutations where it's really important to find out if they're responding or not.
Thank you. We'll go to our second speaker, Dr. Jennifer Goralski. Thank you. So we'll invite Dr. Jennifer Goralski up from University of North Carolina at Chapel Hill, and she'll be speaking on obstruction, mucus, and mucociliary clearance.
So I'd like to thank the moderators for inviting me here to take on this Herculean task of discussing obstruction, mucus, and mucociliary clearance in 20 minutes. And as I was preparing this talk, I realized that it's actually more of a, oops. What's that? Mm-hmm. Click the what?
Click the screen.
I certainly knew how to use a computer. I realized it's not just Herculean, it's actually Sisyphean. And if you know who Sisyphus was, he was a king who was cursed in the afterlife with perpetually rolling a ball, a stone, a boulder up a hill. And because Paul and Simon and Marcus wouldn't stop publishing papers, I therefore was also dealing with this in the task that can never be completed. And we're certainly actually not done. So here are my disclosures. And we're going to start off talking about mucus. So mucus is a complex aqueous, viscoelastic secretion that contains water, protein, electrolytes, and lipids. And this is a relatively old illustration of MUC5A, MUC5B and MUC5AC. We're going to talk about these particular mucins overall. I'm sorry, I'm on the wrong slide. Apologies. Going back to this slide, so here on the left, this is a cross-section view of a ciliated epithelial cells along with goblet cells. We have our periciliar layer where our cilia extend out, and the mucus layer on top that's interfacing with the air. And this down here over this side over here, this is a BAL sample of mucus flakes that was taken from a preschooler with CF. And here staining in green here is the anti-MUC5B antibody with the red in anti-MUC5AC antibodies, and the blue are nuclei from inflammatory cells, same with DAPI. And so when this mucus is actually treated with a reducing agent called TCEP, we get a resolution fragmentation of this mucin network. And here are scanning electron micrographs of the same concept. And so now I am actually going to focus more on MUC5B and MUC5AC. And so these highly glycosylated glycoproteins are secreted by airway goblet cells and as well as the submucosal glands. And MUC5B dominates in secreted respiratory mucins, and they form strands that sweep in airways and remove inhaled pathogens. And Murray models have suggested that MUC5B is a requirement for basal mucocellular transport, whereas MUC5AC mostly predominantly reacts to external stressors. And so I suspect that we'll be hearing more about this in the presentation that's upcoming from Dr. McNally, but there are specific inflammatory and immune response mediators that can actually activate mucin gene regulation and airway remodeling, including goblet cell hyperplasia. And so here on this right figure, we have a total mucin concentration over on the right and normal versus CF. You can see that the concentration is significantly elevated in people with CF. And in the same paper graphed here is the osmotic pressure that's produced here. The green cells are healthy controls. The purple squares are patients with CF, and the black triangles are from explanted lungs. So just to take us back a little step and talk about mucociliary clearance and cough-mediated clearance in particular. Starting on the left, here's a healthy airway with well-balanced epithelial sodium absorption and chloride secretion, which allows for hydration of the airway surface liquid layer, promotes efficient mucociliary clearance. Moving over to the middle column here, when you have a muco-obstructive airways disease, an imbalance of ion transport coupled with mucus hypersecretion demonstrated here, you have an increase in your mucin concentration, which collapses the PCL, and the cilia are no longer able to beat effectively and move mucus along for mucociliary clearance. Up here demonstrates the effect of cough clearance in that the cough itself can actually shear mucin off the surface of the airways. But in the absence of any cough or effective mucociliary clearance, we get this increased hyperconcentrated mucus on the surface of the airway cells with leading to infection, inflammation, and obstruction of lung disease. So I'm going to touch on airway mucus rheology. And so this is the concept of how materials deform when exposed to specific forces. And so two things to think about are the elastic modulus, a unit of measure that of how a substance resists change to elastic or springy deformation. and the viscous modulus, which I think of as the gum being pulled out of the child's mouth, reflecting the flow of the substance while it's deformed. And so Scott Donaldson and colleagues just released this paper just a few weeks ago in JCF, and this is the results of the PROMISE study. As most of us know, the PROMISE study was following patients prescribed ETI, and the MCC subgroup recruited 44 patients to do baseline mucociliary clearance scans and follow them up post 1 month treatment of ETI. And so they also looked at sputum rheology in this, as well as percent solids and exhale breath condensate. And what we see here is there's a lot of variability in the measurements of the elastic modulus, the viscous modulus. And it was probably this variability that led there to be no significant change in the actual sputum rheology. However, when they looked at percent solids within the mucus, and this is essentially a ratio of wet to dry weight or a marker of airway hydration, they did see a significant change with treatment with ETI. And unfortunately, we did not see a change in EBC either. This study was also recently published, and they took this a little bit further. Again, their data tracks out at the 1 month mark with ETI, the same as the PROMISE study did, in that they saw no change from baseline in their sputum rheology measurements. But when they looked at 3 months and 12 months, they actually saw a significant improvement in the viscoelasticity of the mucus, suggesting that longer treatment might actually improve this further. So now I'm going to turn my attention to mucociliary clearance, which I think most people are familiar with, but a nuclear medicine scan in which we track radiolabeled particles out of the lungs. And so again, coming from the PROMISE paper, the main outcome was looking at whole lung clearance. And so here we have measurements over the first 60 minutes, after which the subject would perform cough in order to assess for cough clearance, and then do final measurements out at the 6-hour mark. And you can see a substantial improvement between baseline and treatment in whole lung average clearance, and indicating an enhanced mucociliary clearance. And over here, this waterfall plot suggests that the vast majority of patients showed a fairly significant improvement in their mucociliary clearance. And the authors further broke it down, looking at both central lung clearance and peripheral lung clearance, and were able to see a substantial improvement in both. Just taking us back a step to look at the prior modulators, ivacaftor showed a very similar kind of graph where they saw improvements at 1 month and at 3 months compared to baseline with treatment. However, we did not see that change with lumacaftor ivacaftor, and data for tiscaftor ivacaftor is not publicly available. So I'm going to move on to talk about airway obstruction, and there are lots and lots of ways to look at airway obstruction, many methods in which to do so. And so I'm not going to spend a lot of time talking about FEV1 because I think we've seen that in a lot of data both before and after this talk. But I am going to touch a little bit more on a lung clearance index, the marker, the number of lung turnovers that we see in exchange of a known quantity of gas. And I'm going to focus pretty heavily on CT and MRI as our imaging biomarkers that we're interested in looking at. So I really like this paper that came out last year. This was a retrospective single-center observational study, and we were just mentioning the compassionate use program in France. So the patients that were enrolled in this study, and there was only 12 of them, but they all had fairly significant lung disease. They either had an FEV1 of less than 40, or they were awaiting lung transplant, or they had a lot of pulmonary exacerbations, and so they were eligible for the compassionate use program. And so what these folks did did a blinded review of their Brody 2 scores, which is one of the methods that we use to assess CT scans. And you can see here that they're pointing out to us bronchial wall thickening that has improved from pre to post-treatment, as well as mucus plugging here is pretty substantial, even in these severely affected patients. And so if you're a person who prefers graphs, there's their data there. This other study was also very interesting to me. Again, a retrospective observational study, and this was in 22 people with CF, and they actually had really long intervals between their baseline to ETI treatment and even from ETI treatment to their follow-up scans, because these were all clinically obtained CT scans. And so again, you could see the changes in the visual improvements that you can see in their CTs, and the focus here being on the improvements in mucus plugging and peribronchial thickening. But what I found really interesting about this paper was that they also used AI segmentation of these CTs in order to further enhance their assessment of the CT scans. And if anyone has ever been involved with analyzing imaging for clinical research purposes, it's a laborious and tedious process. And so this concept of using AI to be able to assess these factors for us is a really appealing one, of course. And so they looked at a number of different AI parameters, including wall thickness, luminal area, and the wall percentage is essentially a ratio of those things. And they found that they were able to detect improvements before and from with ETI use in all these different areas. Interestingly, they also assessed this bronchiectasis index, which is a measure of bronchial narrowing. And the concept is that the bronchial lumen should taper from the central to the peripheral airways, and a higher index means that that hasn't actually occurred. And so they had some thoughts about why this index might actually be higher in the post-ETI treatment, and that included higher visibility of these vessels further out in the periphery, that these vessels had been previously mucus plugged, and they had a higher luminal area due to the reduction in the mucus plugging and the wall thickness. So Dr. McNally just shared with us this data that's currently in press from the RECOVER study, which is a multi-center post-approval study in Ireland and the UK. And they looked at a lot of clinical markers here. You can see them here. And the table is separated into all participants, those that are homozygous for F508 and those that are heterozygous with a minimal function mutation. And you can see all the improvements and the things that we've seen as part of our clinical trials as well. So they had 117 patients in this trial from 7 centers, and they importantly did spirometry-controlled CTs, and so they knew they were getting their CTs done at standard lung volumes each time, and they analyzed their CT scans using the Pragma CF scoring, which is a fairly rigorous model to use for CT scoring. The figure over here demonstrates also, again, the improvements in trapped air, mucus plugging, and bronchial wall thickening, though not bronchiectasis itself. So Dr. Graber and Dr. Mall just published this as well, looking at LCI and MRI, and again, separating out our patients into heterozygotes and homozygotes. They showed an extensive reduction in LCI. This was a total of 79 patients who had paired LCI measurements, and then 41 patients with paired MRI measurements. And these MRIs were done approximately 2 to 4 months after ETI had been started. And so we can see the overall global score, as well as the morphology score and the perfusion score, with substantial improvement from baseline to treatment. And again, reiterating the fact that there seems to be mostly improvements in the airway wall thickening score, and in this particular model of how images are assessed, it's combining airway wall thickness with bronchiectasis, as well as the mucus plugging subscore. So this study was a smaller retrospective observational study, but I wanted to include it here because in their center, it's a standard of care to perform MRIs at their annual visits. And so this A, B, and C graphs up over here actually reflect patients with CF who were not treated with modulators, so our control population, versus those who were treated with modulators. And I think that's an important thing to continue to look at, the differences that come over time between treated and untreated patients. And then moving on to some more functional MRI studies where we're looking at assessments of both ventilation and perfusion, as well as our structural changes in MRI and also LCI and FEV1. This particular group did this MRI study that showed a total overall improvement of again, mucus plugging and bronchiectasis or airway wall thickening. But what I really wanted you to see was this really nice graph of a patient. I believe this was a almost 14-year-old patient. And here's a T2 weighted image where we can see this area of probably mucus plugging and atelectasis that has significantly improved after treatment. And because this is a functional study, they were able to create fractional volumes of volume maps and perfusion maps for the patient. And so with blue being the more deficient areas, we can see the actual improvement in lung ventilation as well as perfusion after treatment. So our work at UNC has been predominantly focused on multi-breath perfluorinated MRI, and we also did a similar kind of study looking at pre and post ETI. Our study collected data at baseline and then 1 month after the patients were treated with ETI. And in perfluorinated gas MRI, we're able to characterize ventilation kinetics because we're using a multi-breath protocol where patients breathe in and breathe out, so we can see just how fast the gas is entering or leaving a particular area. And so our morphologic findings with UT MRI were very similar to what's already been presented. But what we were able to show after only 1 month on therapy was that some of these regions that you see here in red that are characterized as true ventilation defects, some of them went away entirely. Others of them improved, but were still defective. They still had prolonged gas washout times. And so so there was a sort of a scale of improvement overall. So I think a lot of this data leads to some outstanding questions, and some that I came up with as I was reviewing was, how about LCI? Does it correlate with imaging parameters? Because I saw some different results. And then does ETI result in improvements in true bronchiectasis? And I think the jury is still out on both those questions. The RECOVER study was able to show these correlations, and LCI is down here on the bottom, where we see that LCI actually correlated really nicely with the various components of the MRI study that they were reviewing. And that was at baseline and at the 12-month mark, although when you look at the changes in these parameters over the same time frame, the correlation is slightly less. Some of the other data, including ours at UNC, did not suggest that there was a correlation between LCI and imaging scores. And there was a suggestion that we're actually measuring different things, that the LCI is really getting at more of a peripheral lung disease component, whereas the majority of what we can see via CT and MRI is a more central location. So we're actually not looking at the same thing when we're measuring these things. And when you think about bronchiectasis, it becomes even tougher. So I think we all know bronchiectasis when we see it, but when you're actually trying to define it as part of a clinical trial, it becomes a lot tougher to nail down, is this true bronchiectasis or not? And so this paper was published in Lancet Respiratory Medicine last year, where they assembled an international group of experts to talk about what actually constitutes bronchiectasis when you're reviewing a CT scan or an MRI. And they concluded that it was actually a combination of these two factors. They had the highest scoring rate amongst the consensus, that it was both an inner airway to artery diameter ratio of greater than or equal to 1.5, as well as an outer airway to artery diameter of greater than or equal to 1.5. And so when we take that into consideration, and we go back to Dr. McNally's data here regarding whether or not bronchiectasis was present during the RECOVER study, they used the Pragma CF scoring system, which is, like I said, a very rigorous CF-specific scoring system, and showed no difference in bronchiectasis. But then this paper just came out a few weeks ago as well. This is using ultra short echo time MRI. Again, a particularly rigorous process to look at both the segmental extent and the severity score of bronchiectasis. That was their main focus of looking at these measures, and they actually did see a change in bronchiectasis. And so I think that we do need to agree on definitive criteria in order to call bronchiectasis. So I'm just going to summarize my takeaway messages for you is that I think we can fairly confidently say that we can see changes in mucus percent solids and MCC occurring by 1 month of treatment, and changes in viscoelasticity seem to be occurring a little bit later, closer to 3 months. And that we have multiple different parameters for which we can measure obstruction, including FEV1, LCI, bronchial wall thickening, mucus plugging. And we can see these really early on after treatment, 1 month of therapy, and persist past a year. But the improvements in bronchiectasis that have been demonstrated largely seem to depend on the definition that was used. And I just pulled this information from that Lancet respiratory medicine paper, and I thought it was pretty telling for a lot of the different biomarkers that we use, that the data seem mostly derived from uncontrolled and retrospective clinical CT imaging using a variety of scoring systems, variable periods of follow-up. Expiratory imaging necessary to detect trapped air has usually not been performed. With the rollout of the rapid rollout of ETI therapy and the COVID pandemic that happened almost simultaneously, I think retrospective studies are unfortunately all we have to hang our hat on at this point in time. So there's a highly variable number of imaging approaches that can be used, and I think it behooves us as a community to really come together and try to come to a consensus about moving forward and studying future therapies. So with that, I'd like to thank the team that I work with at UNC, and happy to entertain any questions.
Thank you, Dr. Goralski. Amalia Magre, Seattle. Please forgive a question from a statistician. I've been enjoying your work for a while, and I keep getting excited about the idea of imaging being the next objective endpoint for health. And I just wonder, when you see the discordance between LCI and some imaging measures, I wonder if it's because we haven't found the right imaging measure yet, or are we... Thank you.
I mean, you've hit the nail on the head. That's precisely the question we all keep asking each other, right? I think that the group that's studying hyperpolarized gas MRI, they've developed a consortium. They're really trying to standardize the approach, and I think that's going to be incredibly helpful. But a lot of this work is being done by, a few centers here or a few centers there, and hence we can't put together that large volume of data that's done in a consistent manner. I mean, your study with doing spirometry controlled CT, right? Most places when they get a CT clinically, they're not doing a spirometry controlled CT. And so if you're looking at this data in a retrospective fashion, you're just using what you can get.
Thank you for this amazing presentation. Ted Narikas, University of Chicago. What do you think the reason for the delayed response in terms of mucus plugging to the therapy is? Do you think it's due to damping down inflammatory effects, things like DNA and other things that may change the rheology of the airway lining fluid that may take a while to elaborate?
Yeah, it's really interesting, right? Because in the study, obviously, the FEV1 criteria, if you're using that to measure your response to obstruction, and considering mucus plugging as a part of obstruction, we saw that really early, right? 2 weeks on. And then we saw it, at least in our study, we did our MRIs a month after therapy. And others have done so as well, whereas you didn't actually see changes in the rheology of mucus, right, early on in the PROMISE study. And so it's hard to reconcile those varying factors. Scott's sitting right next to you, so I might call on him and see if you had any thoughts about why the rheology. I mean, was it just the variability of the measurements? I know you guys were talking about whether or not the transport of the samples to a single center, right, and how that can change if the situation is not well controlled.
Yeah, we didn't do the later measurement in our study, so we only had baseline in 1 month, and variability certainly was a huge issue. We were doing this on a multi-center basis, so that did require transport of samples to UAB, where Steve Rose group did the measurement. So I can turn it to Marcus then, who did the other.
Let's do that.
And I was surprised as well, frankly, that I was happy that we saw the same thing at 1 month, but surprised that something additional was seen at 3 months. So Marcus has the answer, I'm sure.
I don't have the. Oops, I obviously don't have the answer, but I mean, we were very surprised as well to not see a change in rheology parameters at 1 month, knowing the clinical response, and that hydration is something that is really, initiated very early. We were somewhat reassured when we saw your independent data that basically showed the same. And I think it is true there is a large variability, but I think that is also part of the nature of the sample. So there is with many things we look at, if we look at, mucus, inflammation, infection, there's huge intra-individual variability. So I think that's part of the nature of the sample. What we didn't have a chance to do the percent solids measurements because we're doing so many other things. We just ran out of mucus samples. But I think what we are thinking is that there's probably another defect, in the mucus that takes longer to get corrected, i.e. potentially cross-linking of mucins with disulfide bridges that can be, as a result of oxidative stress and chronic inflammation. And if we look at the inflammation, it also does take some time to come down. So that's our current hypothesis.
So presumably all of the research into mucus is for patients who are still producing mucus, right? So I do not produce nearly as much mucus as I used to. So then has it been investigated to see how people mid-exacerbation that are on ETI, how their mucus, and if there is a change in that type, in that patient population?
So collecting mucus samples mid-exacerbation
Right.
if they start producing.
Right.
I don't know the answer to that. Does anyone know if anyone's been investigating that? Well, we have our task. Thank you, Trey.
That's my contribution.
I love it.
Thank you, Jennifer, for summarizing about 10% of PubMed this year.
Thank you. Yes.
So I just want to be clear that we are taking time to do directed Q&As for each speaker, but certainly conserving time as the appropriate symposium format to my boss, Dr. Schmiel there, to make sure that we can get a group Q&A and get all of our presenters in a panel discussion. So please, if you have additional questions, we'll certainly have time after the final presentation for a full group Q&A across the group. So we'll introduce our next speaker then.
Yeah, thanks again for a great talk. And our next speaker is Paul McNally from the University of Dublin, and he will review the data on inflammation and immunity.
Do I do this? Just double click it?
Yeah, click that right there.
Oh, start. Okay.
Yeah. And then you'll click the left side. And then just click right here. And then the clicker will work for you.
Okay.
The right side.
Right.
Yep.
Okay. Great. Thanks, Mel. Okay. Thank you to Deepika, Marcus, and Trey for asking me to speak at the session today. It's great to be speaking in such an interesting session. I think there's a lot that we don't know, and we have a lot to do. So here are my disclosures. Okay, so in terms of an overview then, I'm going to talk a little bit about the abnormal inflammation and immunity in CF. We'll discuss for a second about measuring and what that entails. I'll present some real-world data. I'll have less basic science and more clinical real-world data. Then we'll try and discuss a bit like what do those data mean and what does the future hold. So there's some things in medicine that are simple and straightforward and easy to get your head around. This, unfortunately, is not one of them. And you can see from the talks that we've had to date and also from my talk and subsequent talks that this is an area that's hard to get your head around. And so when we have things that don't 100% add up and we can't get our head around them, we've got to go back to the greatest discovery ever by humans, which is ignorance. And as scientists, we've got to embrace complexity, embrace ignorance, and with a spirit of curiosity, start again. Because we're doing that in CF, really in post-modulated CF, as we're starting again. It's a new disease. And so hopefully we'll learn a little bit more about that throughout the conference. Okay, so I want to talk just a little bit, very bigger picture about abnormal inflammation and immunity. So in health, this is a very delicate balance that's taken a lot of evolution to arrive at. So we want to defend ourselves against pathogens. We want to attack them when they arrive. But in doing so, we have to protect ourselves. So this defend, attack, but protect is really, really important. In CF, a small error with one insignificant chloride channel is enough to throw things askew with this delicate balance. So we get impaired bacterial clearance, we get unusual and recurrent and then ultimately persistent airway infection and sustained airway inflammation. We get neutrophil recruitment and activation and a downstream imbalance between proteases and antiproteases, which causes airway injury, which further impairs airway clearance at a macro level. And I think we're all familiar with this constant feedback loop and vicious cycle. So the question in terms of the involvement of CFTR in this is, when we take an individual who has all those issues in that vicious cycle, what's the contribution of CFTR dysfunction? And will improving CFTR function help? If it does help, how normal does CFTR function have to be in order to have a organ-specific role here in terms of infection and inflammation? And you can see, just exactly what Jen was just referring to about that inter-individual variability, and Marcus as well in filling the question. A lot of these are very individually variable between people, so making it even a little bit more complex. Okay, so measuring it. So let's think about the airways of somebody with cystic fibrosis. Okay, so we start with CF airway dysfunction. If you just look at the airways on their own and look at the cells in the airways, they have CFTR dysfunction and they don't work as well as they should do. From day to day, that intrinsic CFTR dysfunction in those airway cells is probably reasonably stable, but it may vary over time. But it's definitely different between individuals, I think. Then we have mucus and inflammatory cells. So the mucus, as we've just seen, is abnormal. The inflammatory cells also express dysfunctional CFTR. And mucus, inflammatory cells, and resident cells all talk to each other constantly. And the mucus and inflammatory cells are definitely variable over time, and that's probably linked to infection and possibly other factors. And then we have intercurrent infection. So last week, if you didn't have influenza, and this week, if you do have influenza, if you took a sample last week, it's going to be grossly different to the sample this week. And infection is going to interact with all of those other factors, increasing the level of variability as well. And then we've got to think about the biological samples. If we go and do a bronchoscopy on somebody and sample the right middle lobe, and that's all we sample, we're going to get a very different result probably if we sample, one single different lobe, or we pool all of it together. If somebody is on ETI, for example, has got a tiny amount of sputum and they give a sample that's 90% saliva, 10% sputum, that'll look different to one that's full of sputum. So the concentration representativeness is also very variable. And then we think about the test. if you were to have your hemoglobin measured in Dallas or Dublin or Dubai, it'd probably be pretty much the same, and there's standardization across all of those laboratories. But when we look at the type of tests that the data I'm going to show you, they're not really standardized. You can buy different kits that'll do it in different ways. It's operator dependent. You may not do as much replicates as the person next door. So there's a lot of variability in that as well. So this lends some credence to some explanation, I suppose, for the huge degree of variability that we're going to see in the data that I'm going to present. Okay, so before we even look at the evidence, let's remember that in each individual that we look at, they have different levels of CFTR function and different levels of rescue with treatment. CFTR modulation in this context is likely to be only one part of a very complicated picture. When we intervene might be important, and that was alluded to by Simon. And the tests and measures that we're using, they're imperfect. It's all that we have, but it's imperfect. Okay, so let's talk about some real-world data. So obviously the first highly effective modulator, and I'm not going to talk about dual modulators in this session. The first highly effective modulator is ivacaftor. And I think through the introduction of ivacaftor, this is when the CF community really cottoned on to post-marketing and post-approval studies, and we're doing them really well now compared to other diseases. But I think we've learned a huge amount. So there wasn't very much going on in the early days, although there's three that I'm going to talk about. The first is the study between Seattle and Dublin, Ed McCone and Pradeep Singh's groups. And they looked at ivacaftor introduction in a small cohort of adult patients, 12 patients, mean age of about 30 and mean FEV1 of 64. And on the left-hand side, I'll see, does this, oh, no, it doesn't work. On the left-hand side, you can see the pointer. You see that? No, for some reason I can't point it out. On the left-hand side, you will see that's in days. And on the right-hand side, that's in hundreds of days. So in the short term and in the more medium to long term, you can see a reduction in IL-8 and also neutrophil elastase, although you can also see the level of variability there. So their interpretation was that ivacaftor does reduce airway inflammation in adults with CF. A follow-up paper a couple of years later from the GOAL study in fact had a much bigger patient population. They looked at both induced sputum and expectorated sputum, and mean age of 27 and a mean FEV1 in the induced group of 84 and in the expectorated group of 61. So slightly less advanced disease possibly than the Dublin study. And looking at IL-8, IL-6, neutrophil elastase, IL-1 beta, SLIPI and alpha-1 antitrypsin, they didn't see in either group or in the two groups as a whole any change in any of these mediators of inflammation and immunity. So there they concluded that ivacaftor does not reduce airway inflammation in people with CF. At the far end of the spectrum then was the CLIC study, which was a collaboration between Arrest CF and Shield CF. So we looked at children aged 1 to 6. So these were having annual scheduled surveillance bronchoscopy. And out of the databases, we pulled 20 children who have gating mutations where we had 3 years of sequential data with ivacaftor in the middle there. And then 19 age, sex and timing matched controls with F508L who didn't get any modulators over that 3-year period. And we looked at 2 years prior to ivacaftor, then 1 year after ivacaftor. And this wasn't timed for drug introduction. This was just the sample happened to be before ivacaftor introduction. And we found that ivacaftor does not reduce airway inflammation. And just to show you some of the data, in the pink is neutrophil elastase positivity, in the green is IL-8, and in the blue neutrophil elastase. And we used a statistical model where we looked at the trajectory over time and comparing those with ivacaftor with those with F508del. And no matter how we looked at it, we couldn't get the model to tell us that ivacaftor had any impact on any of these aspects of disease. So certainly in preschool children with CF, Ivacaftor doesn't impact on airway inflammation. And then, of course, ETI came along, and so we had a highly effective modulator for a much bigger population, and much more active research groups looking at real-world studies. So the first paper I'm going to show you is from Benjamin Kopp's group. I'm not going to go through all of this data, so don't worry. And they looked at monocyte-derived macrophages, and they had a kind of a translational study where they did a basic science component and also a real-world clinical component. And you can see the first three figures there: sweat chloride, FEV1, and BMI. So they showed fairly significant improvements in all of them, like we've seen in the other real-world studies and in the trials. And in the top right-hand figure there, did a nice set of experiments where they looked at sweat chloride, a static correlation between sweat chloride values and MDM CFTR function. And there was really strong correlation between the two, actually, which was nice to see. And then they also found that the change in MDM CFTR function correlated well with changes in FEV1 and change in BMI. Which I thought was a very interesting aspect of the study, albeit with smallish patient numbers. I suppose more broadly in the study, they showed that ETI treatment increased MDM CFTR expression, function, and localization to the plasma membrane. And they saw partial restoration of phagocytosis, intracellular killing, and efferocytosis of apoptotic cells. But they didn't see any impact on inflammatory cytokine production. So improvement, but not normalization, which you will see is going to be a recurring theme. So if we move then to some of the more clinical real-world studies, others have talked about this already, the reduction in sputum production that we get with ETI. So this is just looking at data from 3 different studies. So on the left-hand side, that's Jerry McElvaney's group in Dublin, and they looked at 30 individuals with an FEV1 of 57% mean and a mean age of 28, and about a third of them were still producing mucus 12 months later. In our study, we have a much younger average group in Recover with a higher FEV1. We had very few producing sputum at 12 months. And then even in the Recover study with, again, an older patient cohort, again, as time goes on, less and less people producing sputum. So I think this is really important to keep in mind as we look at the next few slides, because we can only measure what we can collect. And so if you're not producing sputum, your sputum isn't part of the studies that you're going to see on the subsequent slides. And so we may be actually underestimating the effect by not looking at people who actually don't produce sputum anymore. And that's a hard nut to crack. So this paper is from Isabel Serme's Module CF group. And these are a mean age of adolescents and FEV1 of 76%. And this is a very short-term study looking at, on the top, sputum cytokines and neutrophil elastase, and then on the bottom blood inflammatory markers. And you can see very substantial reductions in IL-1 beta, IL-8 and neutrophil elastase in sputum. This then is Jerry McElvaney's group again, and so they had 30 people with CF, 10 with non-CF bronchiectasis acting as a disease control group. An older cohort, again 28 with a mean FEV1 of 57. And you can see for the proteases along the top, neutrophil elastase and proteinase 3, significant reductions. And you can see a reduction in number as well as you go to the right. And ultimately at 12 months, not dissimilar to non-CF bronchiectasis. And then on the bottom, IL-8 and cathepsin G, again, a similar pattern here with a reduction over time, but still sitting in the range that we see in people with non-CF bronchiectasis, which is in the abnormal range. So this is Laura Schaup's paper from Marcus's group, and I have a couple of slides on this. So this study enrolled 10 healthy controls, which I think is fantastic to have. and then reducing number of participants with CF over 1, 3, and 12 months. And the mean FEV1 in this group, an older cohort, was lower at 47%. And on the next couple of slides, the star refers to a statistical difference compared to CF at baseline, and the hash is compared to healthy control. So you're going to see a lot of hashes before, during, and after ETI treatment on the next slide, which hammers home the point again that even if we do see improvements, it's still not in the arena of what you would see in healthy individuals. So you can see along the top here, IL-1 beta, a significant reduction compared to CF baseline. Not really seen with IL-8 except at the 3-month time point. And then for IL-6 and TNF-alpha, no significant improvement compared to baseline in CF, but never quite gets to the healthy control level. Similarly for cathepsin G, proteinase 3, SLP, and alpha-1 antitrypsin, we're seeing improvements, but with the protease antiprotease activity, there's more significant changes than we see in cytokines. And actually for SLP, it comes within the normal range at 12 months. So this is just some data from the RECOVER study. The two left-hand side figures are from sputum, and the two right-hand figures are from nasal lavage fluid. Sam Nolan will be presenting this data in workshop 34 on Saturday, and it's at poster 196. So you can see, again, our very small numbers in the scatter plots on the left, but we did see a reduction in IL-8 and neutrophil elastase in sputum. We deliberately collected nasal lavage fluid because we knew we were going to have such problems in collecting sputum samples. And in fact, we're delighted we did it because obviously then COVID came along, and doing induced sputum was a really tricky exercise when we weren't allowed to do it in the hospital. In nasal lavage fluid, although we did see improvements in neutrophil elastase, we didn't see any change in IL-8. And this is a nice small study from the group in Chapel Hill looking at adolescent children, BAL, who had a convenience procedure of BAL. They happened to have it before and after ETI. This wasn't a kind of a structured interventional study. But you see a reduction in neutrophil burden and pathogens in the airway. So an interesting part, and we haven't seen a huge amount of this yet, but I think more and more of it is coming, is proteomics. From Laura Schaup's paper on the bottom left, you can see this nice proteomics grid, and I'll just walk you through it because I think it's very interesting. So in the vertical columns there, you can see as we go from right to left, from left to right, CF baseline compared to healthy, and then all the way over to the right, CF at 12 months compared to healthy. And you can see these columns look very similar. So if we just concentrate on the bottom end of the figure, we can see the groups of proteins we're talking about here. So granulocyte activation, neutrophil-mediated immunity, neutrophil activation, and neutrophil degranulation. So we know like a very active area in CF. So while during the middle, if we compare CF baseline to 1, 3, and 12 months, there was a significant down-regulation of all of these. So these protein pools were getting less and less. It still didn't change the fact that they were abnormal compared to baseline at the start, and they were abnormal compared to healthy at the start, and abnormal compared to healthy at the end. And then the data in the top right, this is just very early data that we only got last week or the week before. We'll be doing proteomic analysis on all of the nasal lavage fluid samples, and this is just 10 individuals. So the two dots that are beside each other that are color-coded are technical repeats, and you can see, thankfully, they're nice and close to each other. And this is a PCOA plot, so the further apart, the more different. And you can see two things. First of all, most of these groups, like the green and the green, or the blue and the blue, are far away from each other, but there are a few that are very close to each other. Again, underlying this whole thing of huge inter-individual variability between people. So when we get a chance to look at all of that data, we'll hopefully come back to you about that next year. Okay, so ETI and inflammation and immunity. So we only know what we can find and measure, and I think we have to keep that in mind. Significantly less sputum producers and much more so in the younger population. So we see improvement, but not normalization in various immune, inflammatory, proteomic and protease, antiprotease issues. And in nasal lavage fluid, improved NE activity, but unchanged cytokine activity. And we don't yet have any data in younger children, but seeing how many sputum samples we've collected in the RECOVER study, I think we're going to be waiting a long time. So what does this all mean? So this is an area of complexity and uncertainty, and the more you dig in, the more complex it gets. So highly effective modulators may eliminate sputum in some, but it doesn't look like they correct inflammation or disordered immunity. So we have to continue to address these, particularly in people with more advanced disease, because they're still there and they're still causing trouble. We certainly need to learn a lot more about highly effective modulators and how these affect CF at various different ages. And I think it's true to say we have to put up our hands. Our sampling and measurement systems are completely inadequate, really, for answering subtle questions about this type of stuff. So what about the future? So if you were to design a drug to improve inflammation and immunity in CF, you do in vitro testing first, then you'll have animal models, and then so we'll have all that data before we start talking about humans. We don't have that because these drugs weren't designed for inflammation and immunity, they were designed for clinical outcomes. So hopefully over the years we'll get more and more of that data, and that'll help us to understand things a bit better. So we need more real world studies. We need to keep going with the data that we're collecting already. We need a practical replacement across the board, especially for younger patients, for expectorated sputum, because it's not good. What we're doing at the moment is not good enough. We need to keep focusing on the end result. And I think particularly in the younger people, the end result, which is obviously function and structure, and we need to keep an eye on that and make sure we're continuing to look at prevention as well. And then hopefully we're going to see a lot of new technologies and new studies like exhale breath condensate and analysis of that data, and hopefully a reliable, repeatable, non-invasive and accurate way of figuring out what level of inflammation and immunity is going on. And I think we have to embrace our ignorance and the complexity of what's going on. And thank you very much.
Thank you, Paul, for a really great talk on the topic, and we have time for some questions.
Hi, Paul. One thing that struck me when you showed the data on the inflammatory biomarkers is that IL-6 seems to be going up, and then potentially going back down after a while. And synthesizing the data from a lot of other studies, when modulators work, seems like neutrophilic inflammation wanes a little bit. So we know the inflammation in CF lungs is due to epithelial dysfunction, macrophage dysfunction, and then neutrophil dysfunction. If we try to, chronologically look at what's happening in the babies, it goes this way, right? And then neutrophilic dysfunction is chronicized. So if we're able to track back in time, if the modulators help us, go back to a pristine state of the epithelium, we'll have to go to a state where the macrophages are inflamed, and the epithelium as well, even if the neutrophils go away. So do you think that's what we're saying at this point? Is that we're saying, maybe a restoration of macrophage responsiveness and hence they're inflamed?
I really don't know. And I think that's just pure, it's guesswork, because on the base of the data that we have at the moment, it's a total mixed bag of, we're seeing a lot of advanced disease. A lot of the big changes we're seeing are in the people with advanced disease, and we really don't know what's happening in the ones with milder disease because we don't have the samples. I think, in an ideal world, we'd have BAL from everybody every week, and we'd be able to, unleash the AI and, make perfect sense of it all. So, I'd be lying if I said I have some kind of, solution or answer to it. I think this is just going to take a lot of teasing out over a lot of years.
Okay.
More questions from the floor? Yes, please.
So I'm curious to know, what do you think about changes in inflammation in peripheral blood? And because there are several reports suggesting that CFTR modulator are changing markers in the blood. Do you see a space for correlating those change in the blood with what is happening in the lung of patients with CF after CFTR?
Yeah, so I think...
Can you repeat the question also?
Oh, yes, I'll just repeat the question. Yes, the question was about blood biomarkers and particularly neutrophil biomarkers in the blood, and do I think they're correlated with what's happening in the lungs? I think from my reading of the literature, it's one of those things where neutrophilic inflammation is compartmentalized until it's bad enough that it's not. So if you look at some mild disease, you're not going to find it systemically, but the more the severe disease is, the more you're going to find it. So it depends on which group you look in. If you look in people with advanced disease only, you'll probably find a correlation. If you look across the board, you mightn't find one because of that compartmentalization, and you only get an overspill if it's bad enough. That's my sense of the literature anyway.
Hi, Paul. Thank you for a great talk. I had a few questions, if it's possible. I was thinking that you showed the discrepancies of the IV catheter for the effect on inflammation, and some studies showed improvement and others didn't. Then you also showed that there is like an increase in inflammatory markers and decrease again. But then it comes back to baseline in I think some of the markers. So I thought, would it be possible that it depends on the timing of your sampling, what you find as a result? Do you understand? Because maybe, I don't know whether you can go back with results, but there you saw like some of the markers are low on the baseline, go up, and then they go down again. And then if you measure in between, then maybe you won't see difference. If you measure at the end, then you will see difference.
Is this Marx's group?
No. So
I think...
Yeah, this one here. Here. You see, like the IL-6, you see it goes back to baseline. Yeah, at first it goes, it's low, and then it goes up, and then it goes down again. So I thought maybe there are differences in the timing when you measure what your outcome is of your study is.
Yeah, I think if you look at that, there's no statistically significant difference from baseline. You see the spread of the data. It is unbelievably variable, the data. So I don't think you can read into that and say it increases then it decreases.
Okay.
Because I think we're trying to think about it in quite a simplistic model.
Yeah.
And we do that with everything, that's kind of causal thinking. We try and say A causes B and B causes C. I think what you're seeing here is huge variability in the individuals who were involved in the studies, huge variability in those measures. And all we can say is there's decent numbers in this study, and there's no statistical significance. So I think beyond that, I think it's probably a speculation. Marcus, you want to comment on that?
I can, add to the speculation only. So, so first of all, another caveat is that these are not strictly paired samples for all time points. That's why we always compared the different time points to the baseline. But this is to Rabin's speculation. The pattern for IL-6 is different from the pattern we are seeing for the other inflammatory markers. So it's really a speculation that this may indicate that there is, epithelial, that it is a biomarker for, going towards epithelial homeostasis potentially. But this has to be tested experimentally.
Yeah. So, okay, thank you. I understand. So then you see that there may be a little bit of inflammation still. So what do you think that it clinically will mean? Because you do see that there is a stable FEV1 and there are very little exacerbations. So do we need to care about that?
Yeah, I think, when you think about this, you have to go back to square one. Like, what are we doing? What's our job? Our job is to start from when we get a patient and to make sure that the rate of decline of lung function and lung damage is as slow as possible. Okay, that's what we're doing here. I mean, you might look at the data and it looks really dramatic in terms of, recovery of FEV1. But I think we have to look at that in much longer term context. So we're trying to slow down that rate of decline. So, by reason of extension, you would expect that if you have somebody that's free neutrophil elastase all the time versus somebody who's now only intermittently with free neutrophil activity, you'll slow down the rate of incremental development of new bronchiectasis. So I think that's what's happening. We're getting it better than it was. We're getting, maybe on the good days you won't have, ongoing development of injury. And then hopefully we'll have more of those good days than not. But I think the studies, the real world studies, like the CT outcome data from Recover will tell us a little bit about that. We're already seeing a genotype-specific effect on the rate of change of bronchiectasis between the heterozygotes and the homozygotes. So I think there's something there, and I expect that's what we'll find, is that we slow things down, but there's still some change, like we saw in the longer-term ipocaftor data. But I think, it's like like you'd say to people with asthma, you want the North Star or the goal of therapy is perfect, using as little treatment as possible. And I think that's what we're looking for here. Is we're looking for perfect. Things might be better, but I think we need to keep going until we can get to a point where we're not seeing those increases.
Yeah. Well, I
Maybe
agree.
as a comment,
Yeah.
I think what's really interesting is that we're now seeing comparison to healthy people as well as non-CF bronchiectasis.
Mm-hmm.
And I think that is really critical. And the question is, now at least for the adults CF patient population with chronic established disease, with the data we have now, it looks as if they are still somewhere in the range of non-CF bronchiectasis. And I would, from seeing these patients, I would expect that it is still important to target that residual inflammation.
Mm-hmm. Mm-hmm.
Yeah.
Has inflammation been looked at separated based on median FEV1, as in like looking at like the 80 to 100% range, 40 to 60, 60 to 80, potentially even more granular than that?
Not in what I've seen. I don't know, Marcus or somebody else might answer that.
Yeah. I think we don't have enough data for this right now, and I think this will really be a key question for the future, to really do sub-studies in groups of different disease severity at a certain age, and then as well as go down in age to study children with early onset lung disease. But I have a question to Paul in this context, and that is in the CLIC study. Weren't you surprised to see that ipocaftor, that is probably as effective in restoring CFTR function and gating mutations as ETI in delta F508, did not have an effect on inflammation?
Yeah.
And I noted that you showed the percentage of neutrophil elastase activity, or positivity of neutrophil,
Yes.
detectability, if you will, of neutrophil elastase activity. But when you looked at the absolute levels, they were probably much lower than in older patients. Is that correct?
And I think we were shocked. So when we thought about that cohort, we thought, well, look, between Arrest CF and Shield CF and 3 years of subsequent data with 20 matched patients in each group, we were really expecting to see a big difference in inflammatory mediators. And these are, young enough subjects, but with enough, about 50% positivity for neutrophil elastase and plenty of IL-8. So we really were expecting to see it. But the statistician, she kept modeling and remodeling the data, and we were beating the hell out of it, and there was nothing coming. So that was a big surprise. But I suppose it comes back to the fact that we still understand very little about it, and I think our big thing in looking at the neutrophil elastase positivity was that this is not the bronchoscopy is a static procedure on one day, and the thing we really want to know is, on any given day, do you have free neutrophil elastase swimming around? If you're a preschooler, do you have free neutrophil elastase swimming around in your airways? And that we really expected to change, but that didn't change. So you take what you get.
Last question for now. All other questions have to be saved to the panel discussion at the end.
No, last comment. So it's just a comment because we see that we decrease a stable status to non-CF bronchiectasis level of the usual pro-inflammatory markers. But what we still don't know is how they behave, for example, in the context of a pro-inflammatory trigger, for example, virus infection. And that's the moment where the bronchial damages and the inflammation triggers. So we should also focus on that. Consider that in the dynamic evolution, in the dynamics of the viral infection. And so I think we should look at that.
Yes, good point.
Thank you for this comment. Thank you for a great talk. And I'd like to invite our next speaker, Lindsay Cavalier from University of Michigan, who will talk about infection and airways dysbiosis.
Should work. Okay, great. Thanks, and thanks for the opportunity to speak today. So we heard from prior talks about many of the mechanisms through which modulator therapy is likely impacting infection, including impacts on the airway epithelial cells, improved mucociliary clearance, and improvements in inflammation and host immunity. And today I'll be touching on 4 additional questions regarding the impact that highly effective modulator therapy has on airway infection. So we'll cover how has modulators impacted airway infection, how do we manage airway infection in the HEMT era, how do we monitor airway infection, and then how do we study infection going forward? So we'll start with the impact of modulators on airway infection. And I'll start this with a quick flashback to NACFC 2019. We were in a pretty different world back then. ETI was newly approved. We had yet to see how its clinical trial benefits would play out at a population level in terms of its impact on infection and other markers. I gave a talk at that conference on the impact of CFTR modulators on airway microbiology, and at that point, we were using data from the ivacaftor studies to try and anticipate the ETI impact on infection. So the couple of points from the ivacaftor data at that time were that ivacaftor use was associated with reduced prevalence rates of CF pathogens, reduced acquisition of new infection. The minority of patients, however, though, cleared their pre-existing infection. The people that were able to clear pre-existing infection tended to be patients that had intermittent rather than chronic infection, and mostly those with milder lung disease. The greatest impact at that point seemed to be on infection in the short term, and the data on sustained changes was more inconsistent with this. So with that as the backdrop, what have we learned since then about the impact of ETI on infection? And a lot of the data that I'll talk about in the next few slides is from the PROMISE micro-study group. So the PROMISE, as we know, was a prospective multi-center observational study to measure the effects of starting ETI. And the PROMISE micro group was led by Dave Nichols and Pradeep Singh. And in this study, they looked at sputum samples from 236 people with CF ages 12 and up. And they measured the microbiologic changes in these samples over the first 6 months of ETI use. And first, they looked at the percent of participants that were culture positive for CF pathogens from baseline or time 0 here across 6 months of ETI use. They observed decreased prevalence rates of Pseudomonas aeruginosa and Stenotrophomonas multifilia. These prevalence rates of these pathogens declined over the first month of ETI use and remained relatively stable over the 6 months of use total. In contrast, there were no significant changes observed in the prevalence rates of Staph aureus, Achromobacter, or Burkholderia. Despite the overall decrease in prevalence rates of certain infections, the majority of pre-ETI infections persisted. So this is the Pseudomonas aeruginosa data shown here in blue. The majority of these participants who had Pseudomonas aeruginosa positive cultures at baseline or start of ETI continued to have positive cultures for this. A minority of participants, shown here in yellow, had repeated negative cultures over the course of the 6 months of ETI. And a smaller minority were negative both by culture and by droplet digital PCR, which is a sensitive, culture-independent method of bacterial detection and quantification. So those were the data for Pseudomonas. There were largely similar results for Staph aureus and Stenotrophomonas multifilia. Here in blue, again, the total number of patients who had positive cultures at enrollment. And again, in yellow, a minority of patients then had repeated positive cultures over the course of ETI treatment. And then again, a minority that were negative by both bacterial culture and also droplet digital PCR. The investigators did do additional work to better understand the infection status of the people who had negative cultures but positive ddPCR results, and did conclude that at least a portion of them had true viable bacteria that might suggest persistent infection that wasn't being detected by culture. So since the minority of participants cleared their baseline infections, they then looked at the factors that were potentially contributory to successful infection clearance. And the strongest signal for this came from bacterial density. The participants with lower density of Pseudomonas aeruginosa at baseline were those who were more likely to become culture negative after starting ETI. So here we have participants who were repeatedly culture negative by Pseudomonas density at baseline. Pathogen eradication, however, wasn't clearly associated with any other clinical features, including things like age, baseline lung function, or medication use. And overall, there was a pattern of sustained decrease in pathogen density over the course of 6 months of ETI use. This tended to start within the first month of ETI treatment. This is the data from Pseudomonas of the change in sputum density from baseline, and was pretty consistent over the 6 months of use. This was, on average, a 2-log decrease, although you can see that there's some variation in this, with some participants having a much greater decrease in sputum density of that particular pathogen, and some participants remaining pretty stable, and some even having an increase over the time course. And then you can see that there were similar patterns with infection with Staph aureus and Stenotrophomonas as well, in terms of pathogen density from baseline across the 6 months of ETI use, suggesting that the ETI impact isn't pathogen-specific for the most part, but is more likely through more general mechanisms that are affecting all of them. But while there was a decrease in the density of the CF pathogens, the abundance of other taxa was mostly unchanged. So the PROMISE Micro team performed 16S rRNA gene sequencing on the sputum samples and then used that to calculate the absolute abundance of these taxa in conjunction with the total bacterial load measurements by 16S copy numbers. And so shown here are the decreases in the calculated abundance, again in red, of the CF pathogens across the first 6 months of ETI use. And you can see those decreased, whereas the stability otherwise of the other taxa that we know are present in the CF airways was measured across the first 6 months of ETI use. And these other taxa are largely obligate and facultative anaerobes that we know are present in the oral cavity, and also have been shown in other studies to be present in the lower airways of people's CF based on studies using bronchoalveolar lavage. In addition to the PROMISE Micro study, 2 additional recent publications have also looked at the impact of ETI in airway microbiology. And the first that we'll talk about was led by Michelle Casey and Noel McIlvaney and their team from Ireland. And then the second was led by Laura Schopp and Marcus Moll and his team in Germany, which we've heard about in some of the prior talks as well. And consistent with the PROMISE Micro data, both of these studies showed that there was a sustained decrease in CF pathogen density with ETI use. These were both smaller studies than the PROMISE Micro study, but did have a longer period of follow-up. And so these were able to look at the changes in microbiology across a year of ETI use. And so both similarly observed decreases in Pseudomonas aeruginosa density that started within the first month or two of ETI initiation and was able to be sustained over the 12-month time period. So how does this compare to what we've learned from ivacaftor? Well, I'll refer back to Katie Heiser's paper looking at 12 adults with CF who started ivacaftor. And in this time, they measured Pseudomonas density at start of ivacaftor use, and you can see in the green line here that was shown to decrease over the first 6 to 7 months of ivacaftor use, but then had a rebound. And by 36 months or so after starting ivacaftor, the Pseudomonas density had really rebounded to be pretty close to what it was at the start of ivacaftor. If we drop the blue line here, that's about where we are now with the studies of 1 year of ETI use. And so I think we're still in that window where it's yet to be seen if we're going to have a longer term rebound in pathogen density over longer term use with ETI. So why might infections be persisting and or rebound on highly effective modulator therapy? And I think there's a lot of potential answers to this, and a lot of these we've already heard about in the prior talks, but persistent airway structural damage, pathogen adaptation, residual host defense impairment, residual inflammation, and residual mucociliary clearance abnormalities are all things that we know are persisting and that may contribute to differences in these patterns over the longer term. So we'll switch gears a little bit right now and talk about new data on ETI impact on tuberculous mycobacterial or NTM infection. And this is something that we didn't have very much information on from the ivacaftor studies. And so the first study that I'll talk about is a retrospective multi-center cohort study from 5 centers in Israel. And this team identified 15 participants with NTM who started ivacaftor, looked at the number of airway cultures that were positive for NTM over the course of ETI, and found first that there was a decrease in the rate of NTM positive cultures following a year of ETI use. Of the 15 patients, 9 of the 15 were able to eradicate their NTM infection. 7 of these patients had Mycobacterium abscessus infection. And those who were able to have successful NTM eradication had improved lung function. So those who did eradicate their NTM are shown here in green. Those who didn't were shown here in red. And you can see an improved lung function trend that differed between those who were and were not able to eradicate their NTM infection. So that provides some encouraging data. I think that needs to be continued on in bigger studies, but that ETI use may be beneficial in terms of helping treat chronic NTM infection. What about new NTM infection? These are data that colleagues and I at the University of Michigan are presenting at the conference here. And this was a matched case control study of CF Foundation patient registry data. And this was a data set from 2009 to 2019. So really preceded ETI use and primarily were people that were on ivacaftor. But we looked at cases of incident NTM infection defined as first positive NTM culture in the registry data, and matched them to controls who had no history of a positive AFB culture and did have AFB cultures that were present in the registry to document negative NTM status. We performed one-to-one matching on relevant clinical variables, including things like age, sex, lung function, and bacterial culture results. And then using conditional logistic regression, we tested associations between CFTR modulator use and incident NTM infection, and found that CFTR modulator use over the year prior to the NTM culture was associated with a reduced rate of incident NTM infection. And how about Burkholderia infection? So at the University of Michigan, John LaPuma has run for quite a long time the Burkholderia cepacia lab and repository, and this is a CFF-funded reference lab where we do bacterial species identification and genotyping of Burkholderia isolates from CF centers across the country. And we're presenting this at the conference as well. We looked at the changes over time leading up to and then following the approval of ETI and then also the COVID-19 pandemic. And you can see here, this is graphing the number of isolates or number of patients represented amongst those isolates by year in the Burkholderia cepacia lab. In blue are the total number of isolates received. In orange are the number of patients represented, and gray is the number of people that are newly represented amongst those isolates, so presumed new infections with Burkholderia. So we'll drop a blue line here before 2020, so at the time of ETI approval and the onset of the pandemic. And you can see that, not surprisingly, the number of isolates received dropped at that point in time and has stayed lower as sampling methods have changed and as sputum production has decreased. But we have observed that new patient infections are continuing at a similar percentage of total infections. So of the total patients we're getting isolates from, we're still about 30% of those are patients that have new infections. So new infections with Burkholderia are still occurring in people in recent years. And we are still continuing to identify at a regular pace episodes of strain sharing within CF centers and also outbreaks of Burkholderia that are impacting people with CF as well. And next, we'll talk a little bit about pulmonary exacerbations and viral infections. And this is a project that was led by Christina Thornton and John LaPuma and the STOP2 study team. This was an ancillary study to the STOP2 study to evaluate the impact of viral infection on pulmonary exacerbations. And in this study, Christina looked at just over 1,200 sputum samples from 621 total study participants. And first found that CFTR modulator use, not surprisingly, reduced the risk of subsequent exacerbation in this study. So that included outcomes of retreatment within 30 days of IV completion and also future treated exacerbations. And I should say that these participants were almost all before the approval of Trikafta. So a very small number of them were on Trikafta, and it was mostly ivacaftor and other modulators. But interestingly, the participants in the STOP2 study who had a viral infection were more likely to be on CFTR modulators than participants without viral infection. And this does not indicate that modulators are increasing viral infections. Our interpretation of this result is more likely that viral infections are remaining stable in people on CFTR modulators, but the overall number of exacerbations, the denominator of total exacerbations, is decreasing. So of the remaining exacerbations, a larger proportion of them are likely to be viral-associated exacerbations in people on modulators. And I'll pause here for a moment to do a little bit of an interim summary of the impact of highly effective modulator therapy on infection. We've talked about how modulator therapy is associated with reduced prevalence rates and density of CF pathogens, reduced acquisition of new infection, and the minority of people who had pre-existing infection are clearing their infections. New infections with CF pathogens are still occurring, and we've seen similar findings across the different types of CF pathogen infection. There's a lot of knowledge gaps here, obviously. So we talked about how we still need to learn more about the durability of the impact of airway infection over the longer term, and if this will follow some of the data of ivacaftor of rebounding over time or not. There's a lot to learn still about any changes in the clinical impact of infection, and if we're seeing different consequences of CF pathogen infection in people on modulators. And then also more information on the implications of these patients who are culture negative but culture independent positive status, and how often does this indicate true chronic infection that's persisting at a low level versus something else. And then finally, more information about changes in the lower airway infections and how the lower airway microbial communities may be responding to modulator use. So next I'll touch a bit on some questions that have come up on how we manage airway infections in the modulator era. And one interesting idea, I think, are ways to optimize antibiotic and modulator combinations. And I'll point here to a study from the Pradeep Singh's group at University of Washington, where they took 10 adults with CF and thought about how could they capitalize on the infection changes that are happening at the onset of modulator use with intensive antibiotic treatment. So they took patients who were newly starting ivacaftor. These were 10 adults with CF who had infection with either Pseudomonas aeruginosa or Staph aureus, and treated each of them at the onset of modulator therapy, or close to the onset of modulator therapy, with an intensive antibiotic course. They used oral ciprofloxacin and inhaled colistin for people with Pseudomonas, and oral flucloxacillin for those with Staph. And in the study, the combination of modulators and intensive antibiotic use did reduce CF pathogen density. So this is the data from people with Pseudomonas infection. And you can see there was an initial decrease in Pseudomonas just with the ivacaftor use in the first bar. An additional decrease was gained when you added antibiotics to it. But overall, this wasn't sustained. And the pathogen infection persisted. The minority of these patients cleared infection. Only one of the 5 patients with Pseudomonas cleared their infection. Only one of the 7 patients with staph cleared their infection. So even though a reduction in density was achieved, clearance was not achieved in most of these patients. But kind of along the same lines, there's a group from Italy, Sagana and colleagues, recently did an in vitro study of CFTR modulators, both alone and in combination with antibiotics against Staph aureus and Pseudomonas. And they found that the CFTR modulators had, just on their own, direct antibacterial activity that was greater for Staph than for Pseudomonas. And the modulators were able to influence antibiotic efficacy. So you were able to get synergistic effects between modulators and antibiotics. These were isolate and antibiotic dependent. There weren't commonalities across most of these antibiotics and bacteria. And it didn't seem to be related to stage of chronic infection. So it seemed to be a pretty specific isolate antibiotic interaction. They also performed a mouse model of Pseudomonas aeruginosa infection and found that the presence of a Pseudomonas lung infection increased the ivacaftor concentrations in the plasma and epithelial lining fluid and the lungs. And these data collectively, I think, pose some interesting opportunities for ideas for personalized treatment that can help optimize host and pathogen-directed therapies with combinations of modulators and antibiotics that are optimized for those particular hosts and pathogens. And the last thing to think about in this topic are the potential for differing modulator impact by disease stage. And I'll put up here a schematic of the microbial succession of CF lung disease. This is from a paper from Ryan Hunter and colleagues a few years back, and shows how a number of studies of the CF airway microbial communities over time show that things start off fairly pristine and relatively bacterial-free. The niche modification in the second panel comes in starting with obligate and facultative anaerobes that are mucin-degraders and help set the stage for then CF pathogen colonization at an early phase, and then eventually the chronic infection that we see in people with CF as well. And we know these transitions take place pretty early in life. Marianne Mühlbach and Matt Wolfgang and their team, and then also multiple studies from the Arrest CF group in Australia have shown that the transition from the pristine to the niche modification occurs in infancy and toddlerhood, and then the pathogen colonization tends to come in the preschool years. So the majority of the data that we have so far on the impact of modulators and infection come from people who are more in the pathogen colonization chronic infection stage. And so some interesting questions, I think, are raised by this in terms of thinking about the timing of modulator therapy, and is there a critical time period where you start modulators and you can help preserve things in a healthier phase, versus is there a reversible window of change where you could have greater benefit with starting modulators at a certain period of time, and overall that the timing of modulator initiation may have implications for optimal infection management. So how do we monitor airway infection in the modulator area? We've talked about this a little bit already in this session today, but we know that CF airway infection monitoring is changing. This is from the recent registry data. We know that number of cultures is decreasing, number of clinic visits is decreasing. We know that ETI is reducing sputum production. This is from the Casey study. People who came into the study at the beginning of ETI use, only about a third of them a year later were able to still produce sputum. And we know from the PROMISE microgroup that this also goes along with a reduction in overall sputum volume. So there's need for continued work in this area as well, and there's some exciting studies going on in terms of thinking about breast sampling or other ways of detecting CF pathogen infection that doesn't rely on sputum production. And the last point is a couple ideas to think about on how do we study infection in the modulator era. And the first is really continuing to better understand the new phenotypes. We've talked already in terms of the mucociliary clearance and inflammation, and then now also infection, that the things aren't normalizing. This is again from the Casey study where they included healthy controls. You can see the blue bar here is the bacterial community profile of the healthy control sputum samples, and if you look at that in comparison to what we have across the first year of ETI use, at 12 months of ETI use, it's closer towards the healthy controls, but it's clearly not normalized in terms of the bacterial communities. And similarly, I tried really hard to keep inflammation out of this, but this is my one inflammation graph that snuck in here, and this was from Marcus's group and the trend in neutrophils over the first year of ETI, and you can see it decreases, but it doesn't normalize, and it gets down to probably pretty close to the levels of people with non-CF bronchiectasis. But I think understanding these new states and where we're ending up with infection and inflammation in people on highly effective modulators is worth considering in terms of thinking about how do we develop new model systems to better study infection and inflammation in the modulator era. And then the last two slides here are to make a point and to think about how airway infection has always been changing over time. Here's CF registry data from the prevalence of respiratory microorganisms from 1991 to 2021. And you can see how over time we've had marked increase in Staph aureus prevalence in green, decrease in Pseudomonas aeruginosa in blue. And if you take these years here from about 2001 to 2019 and blow them up, and this is a figure from Dutch van de Venter's recent paper, you can see that there's been a decrease in Pseudomonas prevalence seen across all ages over time. If you look at any given age and go down from the green at 2001 to the purple in 2019, you can see that at any given age across the years, there's been a decrease in the proportion of people with Pseudomonas infection. And these changes have been largely related to improvements in overall health, nutrition, airway clearance techniques, and that sort of thing. Emphasizing the point that there are many factors that impact CF infections. This is a figure, again, from Dutch's recent paper. It emphasizes that modulator therapy directly and indirectly impacts many of these aspects that relate both to CF airway infection prevalence and also to our observations of the CF airway infection prevalence. I'll just highlight a couple that we've talked about in terms of the direct and indirect impacts of modulator therapy specifically, but keeping in mind all of these features are important considerations for future studies of the impact of modulator therapy on airway infection going forward. And with that, I'm happy to take questions, and I'll thank the clinical and CF research teams at the University of Michigan, and thank you.
So we have just a few minutes left. We'll start with any questions for Dr. Calverley, and then also invite all of our speakers up for questions in our remaining time.
Lindsay, that was great. Thank you very much. I guess because there's been so much talk about potential rebound, I would just share early insights from the PROMISE cohort. Full credit to Pradeep's lab and Sarah Morgan, in particular his lab. So through the main study, 2.5 years, we do not see any evidence of rebound in the traditional pathogens. That study will continue for another 2 years, but that may be a distinction from the smaller studies with IVA.
Great.
I wanted to ask, if you've had a chance or plan to consider modulator use or characteristics of health status, FEV1, for example, in the new Burkholderia acquisition kind of population. Is that possible in the mechanisms you have?
Sorry, can you say that?
Sorry, using the Burkholderia reference lab, can you consider modulator use or baseline lung function in considering new acquisition of Burkholderia or persistence recurrence over time?
We don't have the clinical data that go along with most of it, so it's an interesting question, but it would require probably linking it to registry data or a different type of study because we don't have clinical data.
Thanks.
Yeah.
Okay, if there are no other questions, we are right at time. So I want to thank all of our speakers for excellent presentations today and leave everyone time to get to plenary 1 this afternoon.